Welcome to part 3 of our module on death and dying. In preparing for this module, I came across a quote that I wanted to share with you. I think it's very interesting. What is it that dies? A log of wood dies to become a few planks. The planks die to become a chair. The chair dies to become a piece of firewood, and the firewood dies to become ash. You give different names to the different shapes the wood takes, but the basic substance is there always. If we could always remember this, we would never worry about the loss of anything. We never lose anything. We never gain anything. By such discrimination, we put an end to our unhappiness. This comes from the Yoga Sutras. I've never read the Yoga Sutras, but I think this is an appropriate introduction to our video where, among other things, we're going to be looking at the role of religious practices in our death practices or practices after death. So what will you be learning about in this video? You'll learn about advanced care directives, and you'll learn about cultural differences in end-of-life decisions, in patient autonomy, and views on treatment. You'll also learn about active and passive euthanasia and some of the religious practices after death. Something that's important for everyone to consider, regardless of their age, is advanced care planning. And this involves learning about the types of decisions that might need to be made and considering those decisions ahead of time and then letting others know, both your family and your healthcare providers, about those preferences. And these preferences are often put into an advance directive. And this is a legal document that goes into effect only if you're incapacitated and you're unable to speak for yourself. This might be the result of a disease or a severe injury, and this can, of course, then happen no matter how old you are. And it helps others to know what type of medical care you want. An advance directive also allows you to express your values and your desires that are related to end-of-life care. You might think of it as a living document, one that you could adjust as your situation changes because of new information or a change in your health. So sometimes decisions need to be made about the use of emergency treatments to keep you alive. And doctors can use several artificial or mechanical ways to do this, as many of you know. And decisions that might come up at this time could relate to CPR, ventilator use, artificial nutrition like tube feeding or artificial hydration like IV or IV fluids, and comfort care. When a person is trying to figure out treatment decisions and how they want things to happen if they were to be in a place where they were seriously injured or incapacitated, of course, as each of you could imagine, your personal values are going to be key. So people might ask themselves, is their main desire to have the most days of life, or would they focus on the quality of life? And what does quality of life mean? What if an illness leaves the person paralyzed or in a permanent coma? What if this happened to you and you need to be on a ventilator? Would you want that? What makes life meaningful? If your heart stops or if you have trouble breathing, would you want to undergo life-saving measures if it meant that in the future you could be well enough to spend time with your family? Would you be content if the emergency leaves you simply able to spend your days listening to books on tape or gazing out the window? Would that be a quality of life for you? For many it is. For some, they may not feel that it is. So there are some different scenarios. For example, let's say that a stroke leaves a person unable to move and then their heart stops. If that were you, would you want CPR? What if you were also mentally impaired after a stroke? Does your decision change? What if you're in pain at the end of your life? Do you want medication to treat the pain, even if it will make you drowsy and really tired? What if you're permanently unconscious and then you develop pneumonia? Would you want antibiotics and to be placed on a ventilator? So again, for some people, staying alive as long as possible or long enough to see an important event, let's say like a grandchild's wedding, this might be the most important thing. And so an advance directive can help to make that possible. There are two main elements in an advance directive. There's a living will, and many of you have been asked if you have a living will whenever you go to the doctor. I know that for years I've been asked this. I think as long as I've been, as long as I can remember as an adult going to the doctor, being asked, do I have a living will? And certainly if I've ever had any kind of surgery or when I had my children, I was asked that. And also part of this advance directive, the second element is a durable power of attorney for healthcare. And there are other documents that can supplement an advance directive. So what is a living will? Well, this is a written document that helps you to tell the doctors how you want to be treated if you're dying or permanently unconscious, and you can't make your own decisions about emergency treatment. In a living will, you can say which of the procedures that are described as you're maybe as you're talking about this with your doctor or your attorney. There are many different procedures. Many of them I've already mentioned, like CPR, ventilator use, artificial nutrition. So you're writing down, you are stating what you want, and this then helps others to know what you would want and what you wouldn't want, and under which conditions each of these types of choices applies to you. A durable power of attorney for healthcare is a legal document that names a healthcare proxy. This is someone who makes medical decisions for you at times when you're unable to do so. This is a person who's a representative, a surrogate, or an agent. And this is someone who needs to be familiar with your values and your wishes. This means that they will be able to decide as to how you would, as in the same way that you would when treatment decisions need to be made. And this can be done in addition to or instead of a living will. And having a healthcare proxy or having this durable power of attorney it's helpful in planning for situations that can't be foreseen, like a serious auto accident, for example. Medical orders are written by a medical professional on behalf of a seriously ill patient. So it might, for example, include, let's say, a DNR or do not resuscitate order. And this tells medical staff in a hospital or a nursing facility that the person doesn't want them to try to return their heart to a normal rhythm if it stops, or if it's beating unsustainably using, let's say, CPR or other life support measures. And you might say, well, if a person already has a living will, then why would they need this? Well, if you were to, let's say, go to the hospital and it's a very, you were to be in an emergency situation or in a very precarious situation, having this order right next to your bed can avoid confusion in this type of emergency situation. So then without this order, medical staff will typically make they're going to, unless it's very clearly known to them, they're going to make every effort to restore the person's breathing and normal rhythm of their heart. There's also do not intubate orders or non-hospital do not resuscitate orders. There's also, and there are additional medical orders. There are cultural differences in end-of-life decisions, and a significant difference that you'll find among different cultures is the degree of patient autonomy. In general, in the United States, it's the belief that patients should be told the truth about their health and that they should be autonomous in their medical decisions. There are other ways of approaching medical decisions and health issues throughout the world. So, for example, in Japan and some African nations, they're more likely to use euphemisms to describe conditions. In Pakistan and China, for example, there's a greater tendency to hide the truth about one's health issues. And then in Korea, family members are more likely to feel that they should be making the medical decisions. And in many cultures, there's a belief that doctors should be the one making medical decisions and that patients should not have any, or they should have very little say about important medical decisions. There are also cultural differences in the views of treatment. So for example, research suggests that Caucasians are more likely to express preference for stopping treatment, and that African Americans and Hispanics are more likely to want everything possible done. And some research suggests that this may possibly be due to a lower level of trust of the medical system. Hispanics are also less likely to use a durable power of attorney. And perhaps this may be, as suggested by research, due to a greater concern about offending other relatives. I think it's important to point out that these are generalizations about cultural differences. And within cultures, there can be substantial variation. So we might say that this is what we tend to see happening in one culture and what we tend to see happening in another culture, but that certainly does not mean that that is always going to be the case. There always is going to be variation, and it's very important that, of course, healthcare providers get to know each patient individually and not make assumptions based upon visible cultural differences. Figure 1010 shows you some research data that was collected by the Pew Research Center on end-of-life preferences by race and ethnicity. So you can see some differences among Caucasians, Hispanics, and Blacks, but I do think it's very important to note that there is variation within each of these races and ethnicities. For example, among Hispanics, there is tremendous variation. So just as an example, Hispanic countries are Argentina, Bolivia, Chile, Colombia, Costa Rica, Cuba, Dominican Republic, Ecuador, El Salvador, Guatemala, Panama, and I haven't listed all of them. Those are just some examples. And if you know people from these countries, if you know people from more than one of these countries, you know that there is tremendous variation. And so to assume that just because someone is Hispanic, that they're going to have certain values or ways of thinking or have certain preferences can be a very broad generalization. And we're really making broad brushstrokes then when we're making these assumptions. And the same can be true for Caucasians and Blacks. A topic that some of you have likely heard about prior to coming into this course is the topic of euthanasia. This is a topic that is studied by bioethicists and one that for many has very important religious implications, and this is true among people of varying faith backgrounds. Passive euthanasia is withdrawing life-sustaining support. This includes such things as turning off a respirator, halting medications, discontinuing food and water, and this was the case of a very well-known example of a woman named Terri Schiavo. And some of you may have heard of Terri Schiavo. I'd encourage you to look into her case. This was an example, I think a very important example of passive euthanasia in the early 2000s. And Terri Schiavo had been in a state where she was thought to not be conscious, and her ex-husband, or I should say her husband, who was no longer in a relationship with her, advocated for passive euthanasia, and her parents wanted her to remain alive. And the courts sided with her husband. And the reason that they did was that her husband claimed that she and Terri Schiavo and her husband had had conversations that if she were to ever be in a state where she didn't have much brain activity and was not aware of what was going on, that she didn't want to continue living. Her parents argued that they had never had any type of conversation like that with her, that they didn't believe that that's what she would want. But because her husband was still married to her, the courts sided with him and with the evidence that he supported. And there were many activists on both sides who felt very strongly about their positions. So it's a very important case, I think, for each of you to know about. This is why it's important for each of us to have a living will. And it's important for us to not only in writing express what our wishes are, but also to express that to our loved ones, and more than just one loved one, so that it's very clear and the decisions aren't hard for our family members. So in the case of Terri Schiavo, they withheld food and water, and this caused her to starve to death. And another example of passive euthanasia is the failure to resuscitate. So with active euthanasia, a person is going to be experiencing intentional death. So the person is intentionally going to experience death, usually through a lethal dose of medication. And by the way, the examples that I gave of passive euthanasia, those are just some examples. There are additional ones, but you can see some pretty clear differences here. However, I will say that sometimes the differences aren't so clear. So what you see in your textbook and what I'm describing here, I think are pretty clear-cut. There are pretty clear-cut differences, but sometimes it's not as clear. And I'm sure you can imagine when it may not be as clear. So for example, a person may be given a very high dose of morphine, which could possibly be end a person's life, but it may not end the person's life. And it may be that they're given this high dose of morphine because they've been taking pain medication for so long for incredible pain that they're experiencing due to a disease like cancer. And so then it might be more difficult to discern whether what they're experiencing is a result of, if they were to die, if it was due to active or passive euthanasia. It might not be as clear. Oftentimes it is clear, but it's not always as clear. And so these are types of euthanasia that may be used when a person is in what is called a persistent vegetative state. For example, people who may have massive brain damage or are in a coma from which they won't likely regain consciousness. So I think even as I say those things, probably many of you have some lights going off in your mind as you're thinking about the words like likely. And that's where the ethical issues come into play. And there are many additional ethical issues related to euthanasia as well. But when we say likely, that means that it's not 100%, and that's a potential issue that people have with euthanasia. So active euthanasia is, as of 2016, it's allowed in 6 states. And this is much more controversial than passive euthanasia because you're causing the death of a person through a direct action, and it's in response to a request from that person. And a well-known example of active euthanasia was the death of a terminally ill Michigan patient in the late 1990s, in 1998. And on that date, it was in September 17th, 1998, there was a doctor named Jack Kevorkian. And probably some of you may have heard that name before. And this person was also called Dr. Death. And this was because he used active euthanasia. And he was called that typically by people who were against active euthanasia and even by people who may have thought that that was an acceptable practice. And he videotaped himself administering a lethal injection to a 52-year-old Michigan man who had a particular disease, and the person was only going to become worse and more sick, and the person had elected to end his life, and he wanted the help of Dr. Kevorkian. And CBS broadcast this videotape, and when they did this, authorities charged Kevorkian with first-degree premeditated murder and the criminal assistance of a suicide and the delivery of a controlled substance. And this was because he had delivered this lethal medication to this terminally ill man. And there was no dispute that the dose was administered at the request of the man, and there was no dispute that the man, his name was Mr. Yuk, that he was terminally ill. And a jury, though, found Kevorkian guilty of second-degree murder, and he was sent to prison. Now, I will say that we could think of there being a hybrid between passive and active euthanasia, and we might call this, or we could use the phrase hybrid to describe physician-assisted suicide. And this is a voluntary practice of passive euthanasia. And in this situation, a physician is supplying information or the means of committing suicide, like prescribing a lethal dose of sleeping pills or a supply of carbon monoxide to a person so that the individual can terminate their own life. this type of suicide has received a lot of public attention since Dr. Kevorkian, and it actually happened when this, I think it became very well known after a woman who had Alzheimer's disease. And as you learn, this is a degenerative neurological condition. And Kevorkian had set up a machine that allowed this woman to press a button that delivered a lethal poison to her veins. And Kevorkian went on to assist in the suicides of dozens of individuals who were suffering from terminal, debilitating, and chronic illnesses. So you see here, Kevorkian had been doing this for quite some time. And in 1992, actually, Michigan passed an assisted suicide bill that specifically was designed to stop Kevorkian's activities. But there are some technicalities and questions about the constitutionality, or there were at the time, and so it delayed its implementation. And that allowed Kevorkian to continue assisting in his suicides. Now, like I mentioned, he ended up going to prison, but prior to that, he was charged with murder several times, but he was not found guilty on these numerous instances. But eventually he was found to be guilty, and his case went before the Supreme Court. And when it did, they determined that, or I should say, first it went to Michigan Supreme Court, and they determined that there was no constitutional right to commit suicide with or without an assistant, someone to help you. And they upheld the statute in Michigan that made assisted suicide a crime. And then subsequently, the U.S. Supreme Court refused to hear Kevorkian's appeal from the state Supreme Court ruling. So at this point, in most states, it's not legal. It's not acceptable for anyone to be participating in physician-assisted suicide or to actively be involved in anyone's suicide. And so you can understand why these are some very important ethical issues, and why for many people, this is connected to their religious beliefs. Especially as we think about important issues that are related to death, I think that we begin to see a very significant emergence of religious values and beliefs, and how these then play into not only beliefs about important issues like euthanasia, but of course in practices after death. And these are important for each of us to know. Of course, we live in a diverse society. Many of you know people from various backgrounds, various cultural backgrounds and religious backgrounds. And I know that many of you are planning to work in a healthcare field. And when you work in a healthcare field, it's very important that you're aware of the religious practices, and that you're respectful and thoughtful of those practices that each person has. Now, for individuals, there may be variation within that person's faith, but there are also some general practices that you find within certain faiths. So I wanted to share a few with you, and I think what you'll find is that for each of these practices, they are connected to beliefs about life and death. So first we have Hindus, and after death for Hindus, the soul is reincarnated, taking birth in another physical body or form. So passing from one life to the next, in their beliefs, each soul is on a journey of spiritual development. And this is facilitated in part by what's called karma, something probably many of you have heard of. And this is the concept that every thought and action has a corresponding reaction. And that also, it's important to note here too, in the Hindu beliefs, that one experiences the results of both good and bad deeds over a series of lives. And so the soul is uplifted through every good action performed, and then it's degraded with every bad action. So souls are in a cycle of birth and death, and the soul experiences the results of karma. And as it does so, it becomes more aware of how its actions affect the world and those who are around it. And so this growth of awareness then enables a person to become a more selfless and loving being until enough progress has been made to attain a liberation from the human existence, from the humanly form, and really to then live in a complete spiritual existence. So this then relates to the specific rituals that are tied to the Hindu religion. These beliefs are, And so Hinduism, just like other significant religions, has specific rituals for honoring the deceased and addressing a family's grief. And in most cases, the procedures are conducted almost immediately within a 24-hour period. And this is tied to that belief in reincarnation. So when a person has died and the children live far away, other family members will often hold the body until the children arrive to do the last rites, but it is desired to do the funeral as soon as possible. Also, in the Hindu faith, only a male family member, like a husband, a father, or a son, can perform the last rites. And when the person dies, the family is like in any faith is and among those who are not who do not have a specific faith, they are in a state of grief. But there are specific expectations that are connected to this. So, for example, to respect this, no cooking is done in the house until cremation takes place. And there's actually a saying that the fire in the house is not lit until the fire in the cremation pyre has gone out. And so friends will come in with food, and there are very specific dietary restrictions as to what people can and cannot eat, especially the person who's performed the last rites. The food is often vegetarian, and it even removes things like onion and garlic, and the foods are supposed to be what are considered pure foods. And in the place where the person has died, there's a lamp that is lit to light the way for the departed soul, and water is kept there for its nourishment. And then the next day, the ashes are collected and they're immersed in a river, particularly where two rivers meet in the ocean, and then they're scattered over the earth and in India. So this is for people, if they're living in India, they're able to do this. And then in the United States, there are going to be some variation. And there are only a few of the rituals, and I think being aware of different practices can be helpful for those who work in healthcare, as this knowledge can help caregivers and healthcare providers to better meet the needs of family who are experiencing significant difficulty and loss. In Judaism, the belief is that death is not an end of life, but it's a beginning of a new and better life. And I think you find that also for most people in Christianity, there's that belief as well. And even though the family will mourn and cry on the death of their loved one, they'll take comfort in the fact that that person's soul is now in a better and brighter place. There are specific laws in honoring the dead body, and it's also a tradition for extended family and friends to prepare a first meal for the deceased immediate family members. And this food has to be kosher. So many of you have heard of the phrase kosher before, and this is rooted in history and religion. And this is related to the types of food that a person can and cannot eat. And it's related to how food is prepared and processed and inspected. And it's related to foods like meats and dairy foods and some additional foods as well, including even like eggs and fish and vegetables and pasta and coffee and even packaged foods. So there are very specific rules related to different types of food, and these go back to those religious traditions. If we look at the Torah, for example, that's where you would find that, or the Old Testament. So you would find these traditions. And I want to point out that I think as we think about some foods, sometimes we might, if you go to the grocery store, you might find foods that are considered kosher. Probably many of you have come across those types of foods. I think that you find them more often in higher frequency or in greater volume in cities where you have a lot of people who do practice the Jewish religion who live, but we do have around here in our own area, you can find foods that are kosher, and it is so important if you have a friend who is of the Jewish faith and they have lost a family member, that you are thoughtful of this and you're aware of this if you're going to be involved at all in providing any of the food that's going to be brought to the family who's lost that loved one. And so there's also it's very important that burial happens as soon as possible after death, and that also you may have heard of something called a shiva, and this is where family members will gather and receive visitors. So I think what you find is that there are some overlaps between traditions. However, you will find that much of what you find in specific faiths, especially like as I mentioned with the Hindu faith or the Jewish faith, and then we're going to look at the Catholic religion, you're going to find that there are very specific practices that are followed. Some are more specific than others. And as people who are going into healthcare, which many of you are, it's important to be aware of this as may meet with family members in the hospital who are talking about these things, or as they talk with you about the death of their loved one and how they think about life and death. Having knowledge of this can be very helpful so that you can best support the patients that you're working with. And then we also have the Muslim faith, and Islamic doctrine holds that human existence continues after death. Many of you know this about the Muslim faith, and that this happens in the form of a spiritual and physical resurrection. And there's a direct relationship between one's conduct on earth and the life beyond. And the afterlife is one of rewards and punishments that is commensurate with a person's earthly conduct. So when it's in the Muslim faith, some of you may know this, that when there's a day that will come when God will resurrect and gather the first and the last of his creation, and then he will judge everyone justly. And people will either go to hell or what is called paradise, or what we might equate with as heaven. Or I say we, but people who are of the Christian faith. And I recognize not everyone in this class is, but I mentioned that just because we do have predominantly in our area people of the Christian faith. We don't see as many people of different faiths like the Muslim faith or Judaism or Hindus, although we do have quite a few in our area, in contrast to perhaps what we might have seen like 20 or 30 years ago. And this is again why it's so important for us to have knowledge of these practices and to be respectful of the beliefs that each person has, especially if we're working in healthcare, and then also of people who are our friends, people in the community that we may work with. So for people who are Muslim, the deceased are buried as soon as possible, and the community is involved in the ritual. The body is washed and it's wrapped in a plain white shroud, and prayers are said, and this is then followed by the burial. And the body is placed typically now in the United States, you will see variation, and you will see some variation in different parts of the world as well, but typically the body is placed directly in the earth without a casket, and it's positioned on the right side facing Mecca in Saudi Arabia. There are more than 61 million Catholics in the United States, and as we look at the entire global population of about 7.5 billion people, 1.2 billion are Catholics. And so because of this, you're very likely, especially in our area, because we do have a lot of people of the Catholic faith, to encounter people, if you're working in healthcare, who are of the Catholic tradition. And in Catholicism, funerals usually take place within 2 to 3 days, possibly up to 1 week after the death. And the first day after a death is usually reserved for the family to make arrangements for the funeral. And then the second day is often reserved for a wake or a visitation, which is commonly held at a funeral home, and it may possibly last for 2 days. And at this time, the body is usually viewed. It's viewed at the visitation event and possibly at the funeral. And the wake provides an opportunity for the community to gather, to pray, and to express their sympathies and to pay their respects. The style of wake varies depending upon the ethnicity of the deceased and his or her family. So there are different traditions within the Catholic faith that, so you might see some variation based upon the ethnicity. So you might find that if you look at, let's say someone who is from South America who is Catholic, that there may be some small variation when contrast to, say, someone who is Catholic who is from somewhere in Western Europe or in Southeastern Europe. So the Catholic funeral rites include a vigil service that's celebrated in the funeral home or the church the day or the evening before the funeral. And then there's a funeral mass in the church. And then there's what's called the rite of committal of the body at the cemetery. And the vigil service includes the recitation of the rosary, Some of you have heard of the rosary, and then and this is done with a priest, and then eulogies who are made by family and friends. And the priest conducts the funeral liturgy, which includes a mass and the rites of burial. And this service includes readings from the Bible, singing of hymns, and Holy Communion. And books there also include a hymnal and a Bible and a prayer book. And so many of you may have been to a Catholic funeral, and you might find that there's some overlap between your own experience in attending a funeral if you are of the Christian tradition, and perhaps maybe you're like Protestant, or you might be, I think about people more specifically who might be like Baptist or Methodist, and you will find some overlap, although the traditions in the Catholic faith are much more specific than you might likely find in many of the Protestant churches, where there is variation from actual church to church. And in the Catholic tradition, you're not going to find that variation if you go from, say, a Catholic church in Knoxville to a Catholic church in Johnson City. You're not going to find variation. But you would find variation if you went from perhaps one country to another, or if we're talking about people of different ethnicities living in the United States, you might find some small variations. But because it's such an old faith within Christianity, you'll find that it's very traditional, just like in the Christian Orthodox faith as well. You'll find very specific traditions that are followed similarly around the world. So what will you be learning about in this video? You'll learn about advanced care directives, and you'll learn about cultural differences in end-of-life decisions, in patient autonomy, and views on treatment. You'll also learn about active and passive euthanasia, and some of the religious practices after death. What's next? Next, you'll learn about grief, bereavement, and mourning. You'll learn about typical grief reactions and complicated grief, disenfranchised grief, and anticipatory grief. You'll also learn about Kubler-Ross's stages of death and dying and the dual process model of grieving. And you'll be learning about Worden's 4 tasks of mourning.